Great. Okay, well, thanks everyone. So my name's Conor Tweed. I'm a respiratory physician, and I spend about 30% of my time currently at the MRC Clinical Trials Unit. My interest is in sort of TB clinical trials, statistical methodology, and I've also been a member of the PPI group since 2015. So PPI is kind of a big part of my life and has been for a while now. So today, I'm just going to talk a bit about PPI in general in TB and NTM, and then talk about two projects that I'm going to use the word I'm taking the lead on, but that's kind of like Thomas the Tank Engine trying to pull this mile-long freight train behind him. So it's not been going that fast, but hopefully we'll have some feedback and questions here. So, given that we're talking about patient and public involvement, I thought it'd be good just to start with a case study. This is actually a patient who I was involved with at the very beginning and 6 months later in North Middlesex. We've called her Sarah. That's not her real name, or maybe it is her real name and I'm just throwing you off this end. But she was a 27-year-old Romanian woman. She'd been living in the UK for around about 4 years at this time. And she presented to A&E because she'd been unwell for around about 2 months. She'd been working as a cleaner, but wasn't able to work anymore because she had symptoms of fever, cough, just kind of general lethargy and fatigue. And also she felt profoundly anxious, which is something that she kept coming back to throughout the 6 months. Obviously, given the nature of this talk, she was ultimately diagnosed with tuberculosis based on being sputum smear positive and laterally culture positive with fully drug susceptible disease. And she had a characteristic chest x-ray. I don't actually have a real chest x-ray, but it basically looked like this with this kind of white patch up here, but much, much worse. She was started on treatment, and during the course of her treatment, she came to A&E, I think probably at least about once a week, because she had ongoing symptoms of just, again, sort of general malaise, feeling unwell. She complained of joint pains during the first 2 months and felt profoundly nauseated throughout the entire course of her treatment. And this caused her to continually reattend. Each time she was told that she was fine, she's on treatment and she should go home. And so she did and continued to obediently take her tablets. Ultimately, it, from the clinician's perspective, paid off because she completed 6 months of therapy and was considered cured by us. Her disease symptoms essentially resolved and her sputum became negative. And she gained some weight, although weight loss wasn't really a big part of her presentation. However, she continued to feel not right throughout, and in particular mentioned symptoms of breathlessness, which weren't really a feature at her presentation. And the way that we dealt with her in the clinic was that we told her to come back in 3 months for further review. Now, again, this is not her chest x-ray, but it's just to illustrate a point. When she presented, her chest x-ray looks like this. And when she finished treatment, her chest x-ray looks like this. So this is a story about basically a young woman who was diagnosed with tuberculosis, treated appropriately, from the clinician's perspective, everything was done correctly. 6 months of treatment was given. She achieved microbiological cure and did not, as far as I'm aware, relapse at any stage. But she still had a lot of symptoms at the end of treatment. And as well as that, her course on treatment was, to be honest, pretty terrible for her throughout. And every time she presented to talk about it being terrible, she was sent back home and told to take some paracetamol or given some simple antiemetics or anti-sickness drugs. So I think with this, we can see that maybe the patient's perspectives and priorities don't completely align with the clinicians. In our case, we identified a patient who had TB. We treated her appropriately. We cured her, and effectively that's essentially it. We'll bring her back for review and see how she is. But from her perspective, she's got probably a lot of other questions, like, when will I feel better? When is it okay for me to be around other people? When can I go back to work? What happens if I stop taking this medication? Is it okay to stop taking it for a couple of days? Or is a week too long? Or what if I miss just one dose? Is that a disaster? How can I know the medication is working? I mean, from her perspective, it's like she felt terrible before she started taking it, and then she felt terrible on it, and then she still felt kind of bad at the end of it. So what's the metric of success here from her perspective? And if I'm cured, like you tell me I am, then why do I still feel so unwell? And I saw her at her 6-month visit, and we did a follow-up chest X-ray, and I showed her those 2 films, and she asked me, but if I'm better, then why does it still look the same? My answer was, well, that sometimes happens in TB, but given that you're still very symptomatic, I'll go and speak to the consultant. And we decided that we would just bring her back in a few months' time, repeat the chest X-ray, perhaps do a CT to look for any kind of structural damage at that point. The reason these perspectives and priorities are important is because ultimately we are doing medical research for the patient. And medical research obviously takes on a lot of forms. You can have laboratory-based, you can have epidemiology, you can have a mixture. But at the end of the day, if we don't really have our patients and the public in our minds and thinking about a benefit that translates to them, then I don't think we're doing our job very well, basically. Medical research needs to have patients and the public at the center, because even things like their assessment of benefit versus harm may be different to what we think about. It helps us develop research plans with much more of a clear idea of impact. Hanif and I have been doing some work on drug-resistant TB patient-centered outcomes. And as you move in more and more on what is actually important for the patient, you can design better research questions, you can design better trials, better experiments with clearer ideas of what you want to achieve at the end. Patients can actually help with running of projects, not just clinical research, and they can help with dissemination and communication. And as well as that, having patients on board can reduce the time we spend on fruitless ideas, redirect us if we're kind of going down a road that makes sense to us, but not to them. And I guess also keep researchers quite humble whenever you hear what's important to them and how starkly in contrast it can be to what's important to you. Patient and public involvement is becoming more and more of a thing amongst most of the major funding bodies. Here I've put up the UKRI Medical Research Council, the Wellcome Trust, the NIHR. They all now, whenever you're looking at funding pages, have big sections on PPI, and it is becoming a big focus for grant applications, fellowship applications, everything. The phrase "nothing about us without us" was coined, I think, 500 years ago, and I can't really remember the circumstances, but I think it's a very good motto to have here. Every major funder, as I said, is looking for PPI, and if you don't have it, you have to have a reason for not having it. And most importantly, bring it back to us in the world of TB and NTM. We've actually struggled to have PPI in the past, and some of the reasons are actually pretty understandable. The population characteristics, the research climate, and trying to ask for even more money to fund PPI work whenever you're struggling to get enough funding to get just your project done is a bare bones affair. And also is the research culture, where if no one else is doing it that well, or no one else is doing it that much, then it's harder to be the person who does start doing it. It's not all doom and gloom, in that some people are actually moving forwards with PPI and TB, however. I've got a picture of 6 well-known activists from India and Africa and Eastern Europe who are all trying to lend a voice to the patient experience for people who are actively suffering from TB and who have survived it. There's actually a global TB community advisory board, which works through a mixture of community engagement and does do some research advice as well for mostly European-based projects. And also the the European Lung Foundation is trying to get a PPI group off the ground for TB. So in response to what we thought was a need for PPI and TB, and I think there is a need for PPI and TB, we came up with an idea, which is basically at its bottom line to build a cohort or a group of TB patients and survivors who will be experienced and mentored PPI contributors, a group of around about 8 or 10 people to begin with, who are all either near the end of their treatment or have been treated for TB, who can be, as I said, trained and mentored into research methods and PPI methods, and form a group that can be hopefully called upon by UCL-based or maybe broader-based research that's focused on TB. So the idea is to identify, like I said, somewhere between 8 to 10 TB patients or survivors to begin with, and match them up with one experienced PPI contributor to act as a mentor for them. And I would imagine one mentor to 2 to 3 PPI contributor candidates would be about right. Set up training sessions to impart knowledge and skills and to build these mentoring relationships, and then identify existing projects that are in early design stage to plug these PPI contributors into with their mentor, so they can be part of the development of the project and running of the project in a very supported fashion. And as I said, ultimately that will hopefully result in a group of PPI contributors who can be called upon by other projects to help and provide PPI input. So where we are right now with it is we've done a PPI survey that 18 people have responded to. I'm not sure how many of you are in the room right now, but thank you if you are. And we're currently trying to identify the patients and survivors from clinics. So again, aiming for around 8 to 10. And we're going to plug into existing PPI networks to try and find the mentor figures to come into the project with experience. For the training, we're currently drafting a UCL BRC grant to try and get some money together to do some early work. And then looking forwards, the idea would be to, as I said, engage with these current projects and then ultimately result in a trained and available UCL TB PPI cohort. So this is just some samples from the survey. I chose these 3 questions because in some ways they're a mixture of, well, actually they're quite sort of hopeful answers that were given. So we asked everyone, do you have previous experience with patient and public involvement in a research project focused on TB? 9 people said yes, and 1 person wasn't sure. Do you feel that PPI added value to any of your current TB-focused research projects? Again, 9 people said yes out of 18, so 50%. And do any of your current research projects involve people affected by TB in their planning or execution? Slightly less optimistically, 61% of people said no to that. So, having done the survey, as I said, the next steps will be to identify the mentors through existing groups and develop the training material with those mentor figures for bringing the TB patients and survivors in to try and equip them with basic skills, basic knowledge that they need to meaningfully participate. Allocate the mentors and deliver the training, which would bring us to the end of the UCL BRC grant if we're successful in getting that. In terms of moving forwards with the projects, we still have to finalize that, but the idea is to try and present a range of projects to choose from. So we have a few candidate projects, like orientated in basic science, methodology, and qualitative work. And ultimately, once the idea is once the candidates have had their training, been partnered with their mentor, we can give them some introductory sessions on what projects are available and ask them if any would be of particular interest to them. And then they come into those projects with their mentors and work to help with the design and development and execution. So that's the TB PPI project that we're currently leading on. A final thing just to quickly touch on is an NTM diagnosis project, which is still in a mycobacterial theme, but obviously a different situation. So obviously diagnosis of NTM disease can be, as we know, lengthy and challenging, and often involves invasive sampling, which isn't very pleasant for the patient. Guidelines exist, but there is still quite a lot of personal approach that drives how these patients are managed. Patient priorities relating to diagnosis are actually not very clear, as in, as an example, would a patient prefer to have bronchoscopy done much earlier and undergo the discomfort of an invasive procedure to get an answer faster, or would they prefer to wait and see how they develop symptomatically and see how their sputum goes? The honest answer is I'm just hypothesizing, but we actually do not know the answer to that question. But as a result of that, the research agenda and clinical practice is kind of guided by both researchers and clinicians' agendas, rather than patient priorities and their agendas. So our idea was to come up with this project where we would define the factors relating to that NTM diagnosis pathway that are kind of reported by groups of patients that influence their physical, mental, and emotional well-being. Try to use these priorities to inform the research agenda, and also to provide a basis for the development of clinical care pathways and clinical care packages for more kind of immediate impact. And finally, to produce outputs that will raise awareness of NTM lung disease amongst patient and community groups. So basically getting people together, figuring out what's important, and telling people about it. So with this, we're actually doing it under a co-production approach, which is different to PPI in that it's a much more integrated approach, in that with classic PPI, you have a research body or a research group that you bring patients into to contribute to provide input and advice and be involved. With co-production, what we're doing is we bring patients in to be members of the core research group. So from the beginning, they're there and they're involved in grant writing, they're involved in execution of the project, they're basically treated as researchers or as equal standing to researchers. And we've recruiting these patients through NTM Patient Care UK. The idea is that the project plan, and this is quite, whenever you're writing grants for it, it's quite hard because the project plan is not set in stone and it can go in really any direction. So the patients might have ideas, we have ideas, and the project can evolve down very, very different roads to what you think it will at the beginning, which is good. So in terms of our kind of outline for the project, we're thinking of using these photo elicitation techniques to develop topics for discussion in focus groups with patients and clinicians. If I'm being honest, photo elicitation is something that our colleague from medical anthropology has suggested and is taking the lead on, and I'm not going to embarrass myself by trying to explain it in any kind of detail. But essentially, it's, from what I understand, it's taking a patient and asking them to use photographs taken over a certain period of time to capture what they think are the important issues around their diagnosis of NTM disease. And then we take these photos back, and through some kind of medical anthropology magic, things come out of it, and we have ideas. But again, I'm not going to pretend like I know what I'm talking about. Stage 2 will then be taking the ideas from the photo elicitation techniques and making it into using it to inform a facilitator guide that will then guide us in the focus groups with patients and healthcare providers. And then we'll decide on the major themes from that. We've contacted the UCL Arts and Sciences department because we're going to try and think about novel ways of communicating these results to both the public and to healthcare practitioners. Again, I don't know what that's going to look like, but it'll be very much informed as we go through the stages. Okay, so that was a really quick talk through quite big things, but the bottom line is that PPI is increasingly being recognized as important, which is, to be frank, really good. Whenever I joined the PPI group back in 2015, it was very much a kind of add-on affair. We didn't really have that many PPI SOPs in the unit. Like, I had to help write quite a lot of them. And it wasn't that, in terms of funding and grants, it wasn't really considered that big an element of them. It existed, but it wasn't a big focus. So the good news is it's becoming more and more of a focus in these applications. There's also a really strong evidence base to support its use. Like, it's not something where it's opinion, it is actually a measurable fact that including patients in your research makes it better. And PPI and TB is underdeveloped, and it just is. We've really kind of not picked up the ball on this one, but we are trying to get better at it, trying. And NTM is another challenging disease, and I think patient priorities are essential in deciding how you're going to manage it and how you're going to research it. So hopefully not too confusing, but if there are any questions, happy to take them.
Thanks very much indeed, Conor. Any questions?
Really liked the sound of both of those projects. Just from a practical point of view, for the first one, the TB one, in terms of identifying the patients that are going to be part of the group to be mentored, how do you go about deciding what the characteristics the patient might have that might make them good at that role, apart from obviously asking if they're interested? And again, on a practical point, if I'm sitting in clinic and I identify someone that might be interested or good, how do we go about bringing them into the project? Yeah, so I think it's a really good point. And there's probably 3 parts to the answer. I think the first part is, this is like pilot/feasibility work. So if they're in any way interested, give me a call and we'll bring them in. But like, I think it's quite, at this point, we're quite indiscriminate because it is just a very small group and we're more trying to see if it'll work. The second part is representativeness as a result of that. So part of the reason why TB PPI is not that great is because often our TB patients have quite chaotic lifestyles. They come from perhaps quite difficult backgrounds, or language can be an issue, things like that. So while going forwards, I think we can't take our eye off the ball in terms of representativeness of the patients. I think for this, I'm saying this very carefully, because I think particularly for this part of the project, the initial pilot phase, we probably want a patient cohort who is perhaps more easily able to engage in the work and keen as well, like wants to be part of it. Later on, I'm very keen to make sure that this PPI project stands out because we actually get in the patients who are turning up in clinic. And so that would include people for whom English is a second language, people with no fixed abode, people who have concurrent drug and alcohol problems. But that's going to be a lot of work. That would be a lot of work to create a stable environment for them. And the third problem, or the third part of the answer, I think, would relate to power dynamics. And that's something that we only gave some thought to after we'd spoken to Jess Potter, where at this stage, we're again putting a pin in that and not thinking about it too much. But there is a risk of an unfair power dynamic where your doctor or your healthcare provider approaches you and says, will you be in this project? And you maybe feel a degree of obligation to do it, or you maybe feel like you can't quite say no. Again, I think that's something which we just need to bear in mind and make sure we don't lose sight of as the project hopefully evolves. But the short answer to your question is, at this stage, anyone who seems in any way interested, just bring them in and we'll get it off the ground.
Thank you, Conor. And of course, Conor will be available for questions later. He'll be stationed by a bottle and inviting questions. And it is, I was on a call earlier today looking at trying to document what happens in terms of drug resistance in the UK. And the question was asked, okay, can we get any PPI groups involved? Answer is, we really struggle. And it's particularly germane, I think, to TB and NTM is because no one's really been interested before. But they're very interested. The patients are amazing. I mean, they just drive the whole process. If we can do the same in TB, that would be fantastic.